Well, now we're going to turn to look at some of the regulatory and ethical issues around registries. And so I have a panel have kind of approached the question from three different areas. So hopefully their joint perspectives will give us kind of a three-dimensional view of the subject. So first, I have Mark Merrick, who is is director of the Athletic Training Division in the School of Health and Rehabilitation Sciences in the College of Medicine, and also the vice chair of the Biomedical IRB. And next to him then is Jennifer Elliott, who is the Hipaa Privacy Officer and Associate Director of Medical Information Management in the College of Medicine, and is an advisor into the Privacy Board at Ohio State. And finally, Cheri Pettey, who works with the Privacy Board and Exempt Research in the Office of Responsible Research Practices, and helps researchers in their determining human subjects for research, reviewing the requirements for the subjects in their research. So thanks to all of you, and I've asked them to kind of each talk a little bit about from their perspective, some of the issues involved with registries, and then we'll open it up to questions from you all.
Okay, so I guess I get to start. From an IRB perspective, when we're looking at registries, understand the lens and the filter that we're trying to look at your registry through. Our purpose as an IRB isn't necessarily to enable your research. It isn't to answer your research question, and it isn't to remove barriers specifically that you're trying to do. Our charge as an IRB is to protect participants. And sometimes that gets a little confused along the way, and it makes us really look like the bad guys when we tell you no. But from a registry perspective and looking at participants, really the things that we have to try to take a look at is it research or is it not research? Is it human subjects research or not human subjects research? And in many cases with a lot of the registries we're looking at, where we're following our policies now at the university and looking at informed consent, how do you want to use this information, and is it consistent with what the participant actually consented to doing? You know, one of the biggest areas that we have to look at is respect for persons. It's a Belmont Report principle, and respect for persons really sort of holds us to an individual's information being used in a way consistent with what that individual approved its use for. So, you know, it's really easy from a registry perspective when you're using information in the way that it was intended for its use and that people gave it approval. Where it gets a little harder is when, wow, you know what, we've had this registry for a long time, and there's maybe some information in here that might be useful to my colleague over here who'd like to also use this data. We have to try to look at things like, was that data being used in a way consistent with what the people approved it for? Are there situations where we might need to reconsent or where we have to say no, or what other things sort of fall in there? So our perspective at the IRB side is really very participant protection focused.
Hi, I'm Jen Elliott. As he said, I'm Privacy Officer for the Medical Center. And I think I was asked to kind of give you my perspective on registries from where I sit in the Medical Center world. And I wanted to kind of give you a little bit of history of Hipaa, very briefly, and then also talk about the current landscape of Hipaa, and then talk about, my main concerns about Hipaa and registries. But as you know, 2003, Hipaa was put in place, in the words of HHS, for researchers, requiring covered entities like ourselves, people who hold protected health information, to get additional documentation from researchers before they use protected health information to do research. So to say that Hipaa is not popular with researchers is an understatement. So I should have brought cookies for all of you or something, but anyway. So that was the origin of Hipaa and research. It's been a little contentious. It still kind of is in ways that it's perceived as a barrier to doing research. But so that's the small context. The bigger context is we've had to comply with Hipaa since 2003, as you all may remember. And when Hipaa was first, official, the Office for Civil Rights did very little to enforce Hipaa. So it went for probably a good 5-6 years without much word from the Office for Civil Rights about Hipaa. They have swung into full swing in the past couple of years, and they changed the law, which I'll tell you about in a minute. They've also increased their oversight of places like us, performing research on patient data. So one example is, for the first several years, no enforcement actions whatsoever. They've increased steadily over the past 5 years, and last year they had 6 enforcement actions, the year before 5. And so they're out there. They've also started doing audits on covered entities, so they can kind of show up and do a joint commission type audit. They're going back and forth about what we've heard, whether it'll be a desk audit where they ask us for our policies and procedures, or they're actually going to come here and look at what we do. So we don't know that yet. So that's an example of increased enforcement. Another example is that they put into effect these breach regulations. So in very brief terms, it's a little more complicated than this, but where there's a violation of the privacy rule, and there's a breach of patient information as defined by the federal government, we have to notify the patient. So, dear patient, we're sorry we lost your data because of X, Y, and Z problem with X, Y, or Z database. And we have to notify the federal government. If the breach is 500 or more people, we have to notify the press as well. So there's a lot of nuances to that, but that's the gist of it. Before the breach regulations were into effect, we would notify people in general if we had a big breach, of course, and then also if their social security number was involved. So in some way, it's not a huge change for us here, but it is a big change from my vantage point, which comes to my concerns about research, or my perspective of research and registries. One piece of it is data security. So if the data is not secure, or kept in a place that's not secure, kept on a laptop that's unencrypted, and it gets lost, you folks run in the regions of 500 or more patients. And so data security, making sure that the data is secure on your phone, it's secure on your laptop, your student's laptop, where you save it here at the medical center, your home computer, those are all very important questions to me from a privacy perspective. And we do find that people try to do the right thing. It's just people are very busy, number one. Number two, the technology is, one day it's this way and the next day it's another. So keeping up with the technology is really an important thing. Flash drives, making sure those are encrypted as well. Papers, making sure those aren't lost. Because if any of that happens, we're talking with you about, was this a reportable breach of patient information? And you really want to focus on your research. You don't want to have to worry about that. So that's one piece. The second piece is more sort of bread and butter HIPAA related to research. So if you're going to use patient information or disclose patient information for research purposes or for registry purposes, you want to make sure that you have the correct HIPAA permission to do so. So for example, you can have a partial waiver of HIPAA authorization, a full waiver of HIPAA authorization to use and disclose the information without the patient's permission. You can also use and disclose limited data sets, which is about 5 elements of PHI. If you have a specific agreement in place, you can use or disclose that for public health research purposes or for healthcare operations purposes. You can use and disclose PHI with the patient's authorization, so a signed authorization, you can use it as well. There's a couple other ways you can do that. So if we don't use the proper HIPAA process for using and disclosing PHI for research purposes, we are in the potential breach zone. So we always want to make sure we have our HIPAA ducks in a row before we use or disclose patient information for research purposes. And that's pretty much the view from my world related to registries.
So, sorry. I'm Cheri Pettey from the Office of Responsible Research Practices. We facilitate the IRB's review of projects that require IRB review that meet the federal definition of human subjects research. And we also deal with things that are exempt from IRB review. That's one thing that I do most of in the office, is help people determine if their research is exempt. So as far as related to registries, I help people who are accessing data sets that are outside the institution and determine what kind of review requirements are needed to access the data. I help people decide whether what they're doing is quality improvement quality assessment versus research, and so whether any review is needed for their project. I help people also in a more extended role. I've been involved with the committee that helped establish the university guidelines on repositories and banking, our updated policies. And so I help a lot of people who are thinking of setting up repositories or registries or banks, and the sort of different steps that they have to think about and what they have to go through, and then help people kind of think through where different decision points maybe put limitations on how the data can later be used or how the data can later be shared. And then also help people who then, after these registries are set up, I help people know the proper way to access them depending on your role. So we sort of are the facilitators. We also help everyone make sure that they're complying with HIPAA. We help them determine whether or not waivers are appropriate, and what kind of limitations that puts on your data. And then we also help people determine, how to get in contact with their proper privacy officer or other entities in the university if needed for guidance.
I think at this point then, we'll probably turn it over to questions from you in the audience, since I'll assume my mic role. There's someone on this side has a question.
I was wondering, have regulations kept pace with the recent findings where individuals can be re-identified based on minimal points of data? Several demographic pieces of information can lead to re-identification.
So one thing that the committee that was brought together to look at our banking policies and registry policies was actually sort of related to that, because even entities like NCI and NIH, there used to be this great data sharing and putting genomic data out there, and then with the increase in technology and the resources available, data available, it became clear that people could be identified, whereas we once thought it was de-identified and we could share it in certain ways without further permissions. So that sort of is reflected in the new banking policy that's requiring consent from people so that people are aware of how their data may be used and that it can be shared, and that gives us the greatest flexibility so that everyone can continue to use data as new technology becomes available. Because once you sort of explain to people how you're going to do your best to protect it and how it's going to be shared, then you have greater flexibility when these new things come about, where you don't have to stop what you're doing because you told people you'd never share potentially identifiable data. Now it's potentially identifiable, so now you have to halt what you're doing. And also, it sort of helps because then you have the greatest flexibility to use the data, and you don't have to, as Dr. Binkley alluded to earlier, you run into a wall when you said you were only going to collect X number of data and now I de-identified it. Now with the new rules, if you get permission up front, you can go back more and you can get those extra data points that are now important today that weren't yesterday. So we've sort of taken that into consideration.
Yeah, if I can tag team in on that a little bit. If you haven't looked at the data and specimen repository policy, you really need to do that. There's a lot of thought that went into this policy, and one of the most important pieces is that all future prospective collection of registry data, whether that be tissues or patient information, require consent. And the things we've recommended in those consents is that it is for future unspecified research and that it includes your identifiable information. And we learned a long time ago that a lot of the de-identifiable data sets that are out there, we can't link them to outcomes and other things in the future, and they become less and less valuable. So we know that going forward, we really are going to need to know not just what we collected today, but can we link this to what happens to you 20 years from now? And the ability to do that with a prospective consent really gives you broad latitude in how you use those data and what data that you can collect. Where we see a lot of people get in trouble is we have a very narrow viewpoint in the moment when we're designing a registry and designing a study. And as the last group was just talking about, You know, all it takes is one small change, and suddenly you're asking the wrong question and you have the wrong information. And you can't have any means of going back and finding, recreating, or linking to that information again. So a little forethought in this really goes a long way.
I was wondering, Cheri, is your office kind of the first point of contact then to deal with HIPAA issues, or do you need to reach out to you and also a college privacy officer?
So for research-related questions, usually we're a first stop, and if we can't assist you, we can help point you in the right direction for your college privacy officer. Jen deals with the med center, but you know, like people in dentistry and speech and hearing, they have their own separate privacy officers, different parts of the covered entities. So we can help point you in the right direction. We have on our website, we host the template for obtaining authorization to use PHI. We also, the IRB serves as the privacy board for IRB reviewed research to grant waivers and partial waivers of authorization. And then we have a privacy board for people who are seeking exempt determinations and need to access and utilize protected health information.
Just out of curiosity, are we all, I know we're immersed in this stuff and see it all the time, but is everybody clear on the difference between needing a full HIPAA waiver and needing a partial waiver? No. Maybe that'd be a great spot for us to jump in and clarify.
So when you're dealing with accessing protected health information for recruitment purposes, and you just need to go in and identify your set of patients, then you can request a partial waiver of HIPAA authorization, which just means that you can go in and look so that you can get contact information and find the people that you actually want to ask to be part of your research. So, and then that partial authorization sort of ends there. So if once you approach someone and say, can I use your stuff, they say yes or no, and then you get rid of the information if they say no, and if they say yes, now you have authorization, they've signed authorization, so you're no longer operating under that partial waivers. So any data you collect after that point, you're collecting with their authorization, so that doesn't get addressed in the section of your application where you're requesting the partial waiver. So your justification for the partial waiver is just because you need to find the people that you want to be in your research. And then a full waiver would be if you didn't plan on getting any sort of authorization because your patient population is maybe this is going back 10 years and this is a transient population, you're not going to see them anymore, everyone's already left your care, and for scientific validity reasons you need the whole group. And so that's when you would ask for the full waiver. And then there's also alterations where if you're contacting people over the phone and you can't get their signed authorization because they're all over the country, or you can alter and remove some parts of the authorization. For instance, simplifying some of the language sometimes when you're dealing with certain populations. So that's sort of the high-level overview of
I think where people get in trouble with this is they look and say, well, these are my patients. I did the procedure on them. I want to know how many people had a bronchoscopy between this period and this period and use this instrument, that kind of a thing. So why can't I just look at my own records of my own patients and see how many people I have? Well, where you'll run into trouble there is if you're doing that for a research purpose, that's not part of their patient care. And as a result, you need to get a partial waiver of HIPAA even to look at your own records for research purposes to figure out how many eligible participants and who do I want to try to contact. And that sometimes confuses people because in many cases they're your own records and they're your own patients. But where it becomes a little different is when you're starting to use this for a research purpose. If you're looking at it for other purposes that might not fall under the purview of some of these things, but when you're looking at it for a research purpose, you need the partial waiver to go and see how many of these I have. And if you're doing a retrospective study, then you might request a full waiver to have access to use that information going forward. Those kinds of things are often really, really confusing.
What about, Mark, if you're even antecedent to that, activities preparatory to research, when you, let's say you have a question or formulating a question and you simply want to see, wow, do I even have enough within my own population to even examine that question?
So for preparatory to research, I think Jen can speak to it more specifically, the process that they have for accessing them. But it's really a simple count. So if you don't even know if OSU could participate in a potential clinical trial because you don't know if we have, how many people we have with, a certain condition, you can go in and do a one-time look under preparatory to research to sort of just say, how many people do we have? But you shouldn't be creating a new record. You shouldn't be recording anything other than your straight number. We have a potential of 75 people, or we see 200 people a month with that sort of condition. If you need to record, once you start recording information, or if you need to do any sort of analysis of any point, you're starting to cross over into not only potentially human subjects research that requires review, but then you've also sort of stepped over the line of preparatory to research.
Yeah, I think a piece in that equation really comes down to is how many do I have, or who are they? And the who are they piece really needs a partial waiver. How many do I have is much more in the preparatory. Mm-hmm. Go ahead.
I just have a question about the partial waiver to go back to. So if you have a partial waiver for recruitment purposes, does that mean that you can then contact the patient?
So there are different rules as far as what OSU's policy is and what the Med Center policy is about when you can contact and who's doing the contacting and all of those sorts of
things.
things.
And the who's really important here.
So when you start with the partial waiver is approval to go in and figure out who the people are, and you access and use the information for that purpose. And then the other policies start to come into play about who can contact them. So in general, if it's a direct contact, we don't want any cold calling where someone has nothing to do with anyone's patients calling these patients and saying, hey, I heard you have X disease, we'd like you to be in our study. Usually there's a facilitation, someone who's part of their care is contacting them. But it gets conflated a lot. I mean, the partial waiver is really just the permission to utilize the medical record. Once you get into who's contacting and who can and cannot contact, that's all part of not only your IRB application so that we look at it ethically, but also Med Center policy and who's allowed to be in the medical record versus the actual partial waiver part.
And a lot of what our office does is look at patient complaints, and related to research, that would be one of the top ones, being I was contacted by a researcher over here, and my doctor's over here, and I have no idea who this person is. So they may have had permission under the waiver to look at the information, or they may have had all the appropriate permissions in place, but when it comes to contacting patients, we really like it to be someone they know. A provider that they know, or there's a link between the provider and the researcher before they contact the patient. So,
and even a helpful hint on that is when you make those contacts, identify the link to the participant you're contacting. Hi, this is so-and-so from Dr. So-and-so's office. We saw you about this procedure. We're now doing a study about this, and we'd like to know if you'd like to be involved. That lets them know, oh, you're from my doctor's office who treated me about this condition. Okay, I see the connection. People do not like their private healthcare information being described to them by someone they do not know and who they do not understand why you have my information. Very offensive to people.
And also, I guess, one other thing to note is that just because a partial waiver or even a full waiver is granted by the IRB or by the Privacy Board doesn't give you permission to be in the records. You have to go to the steward of the records, the privacy officer in charge of them, or if it's an external clinic, and you have to ask permission, and they don't have to let you in their patient's records. Once you have the patient saying, please release my records to this person, that's different. But when you're talking about partial waivers to identify your participants or full waivers to collect data, people don't have to let you into their patient's records. And so that's one thing. People always come back to us and go, well, we listed all these people on our partial waiver. Why can't they go into the records? Well, it turns out, the IRB doesn't know that 3 of the people that you listed are volunteers, and they're not part of our workforce. They're not part of the Med Center at all. They're just, somebody's cousin is here for the summer who's a resident, or somebody from College of Public Health wants a job, wants to come in and volunteer in a lab. And so they don't have the necessary credentials where the med center itself will approve access to the medical records, or an outside clinic can just say, no, I don't want you in my records. And so people sort of forget that. They think they got the regulatory determination that they can have a waiver or a partial waiver, but that doesn't give them access to the records.
One other little thing to throw on that is if you are going to be contacting participants, the IRB is going to ask you to get their consent. So we probably won't give you a full waiver if you're contacting people. We're going to expect you to get their permission to use their information.
Along those lines, I was wondering if you could revisit what you had said earlier about partial waivers for recruitment. I think you had mentioned something how you have this partial waiver, you know who you can approach. Someone you recruit declines to participate. I believe you mentioned something about, so then you cannot, store obviously their personal health information. Something that I feel like I keep running into is journals wanting to know all about the people who didn't want to do the intervention and how they compare to the people who actually consented. So I wonder if you could speak a little bit to that in terms of what can you say about people who told you no, if anything?
So generally, I mean, there's the ability to, a lot of people will ask for a partial waiver. Sometimes you want to also get the people who you didn't even contact because you ran into issues like, we had this whole population that sort of seemed like they would meet the criteria, but they had this one thing wrong. And so you want to collect some of the information on that. That's where you can make the case for potentially full waivers of authorization for those people, so that you can collect a very small amount of data, usually de-identified, so you can sort of say, here's the people who didn't qualify and sort of here's why. Also, people will get permission from people to keep refuser data. Like, I understand that you don't want to participate. Is it okay if I keep this limited amount of information? Or a lot of people will even ask questions. Can I ask you a few questions about why you didn't want to participate? And that's really important information, and it's possible to collect. You just have to know, what you're asking for. So at that point, you might get, an alteration of HIPAA authorization where you're only collecting a little bit of data, or if you're just getting self-report data from the person, then you might not even be dealing with PHI anymore. You've used the records to contact them, and now what you're doing is just collecting a de-identified short survey is why someone said no.
But more and more we are seeing consent forms that have a section about refusal to participate, and may we keep this information about you for reporting purposes. So it's 5 years ago, nobody thought to do that. And now we're seeing it all the time on IRB protocols where people are saying, we want to compare, is there a difference between people who don't participate and those who do? May we use the following information for this purpose?
I'm assuming that's something you kind of build in
Yeah.
your protocol with your IRB.
I think the savvy researcher does it on the front end instead of trying to figure it out on the back end.
Thank you. That was very helpful.
As such that you cannot retain any PHI, it's going to be general. Let's say
I mean, you have to still qualify. If you weren't contacting them at all and you weren't getting an alteration of HIPAA authorization where you're actually asking them permission to keep certain things, in general, the partial waiver ends at recruitment. And so sometimes you can keep it for a do not call list, and you can ask to keep information for a do not call list. But once you start getting into what her question was, where you want more information about them later, that's when you need to either ask for perhaps an alteration, or collect things that aren't PHI and it's collected in a separate survey, or you ask for a waiver, depending on if you're afraid you can't get the information you need because of maybe mistrust in the population, and you have to make the scientific justification because you have the person there. But there's the flexibility. You just have to ask.
In the back, go ahead.
Getting back to the registries and creating a protocol that actually is flexible over time, I know we talked about that. What are some of the key elements of the protocols, like when you're establishing these registries, that you've seen in really successful ones that are able to last over time without reconsenting patients? Can you get a little bit more into that? Like, what are the key elements you see in all those protocols?
Who has a crystal ball? That's really what the question comes down to, is how do I make sure I get the stuff I might want later? But good luck with that, because what we see is that we're not even thinking of the things that are going to be important in 10 years. We haven't even conceived them yet. The information that we are gathering now is advancing so rapidly that the stuff that is the most pertinent things to look at now, no one even thought of when I was hired at this university back in 2000. So good luck on guessing what those things might need to be. I think within some limitations, identifying and getting permission to go back into the record periodically for these kinds of information that might be there is something that you might want to seek some permission to do. So we may only be collecting data about this, and this right now. We may think of something in the future that, you know what, oh wow, wouldn't it have been great if I had used that blood 10 years ago? And I might have a genetic profile available to me now if I had bothered to do those kinds of things. So, you know, trying to be broad, but at the same time giving enough information to let people understand what you want to do is a very difficult and challenging thing. So I don't have a lot of really great guidance on you. You know your areas of research far better than the IRB ever does, and that's one thing sometimes that people forget when they write a protocol for us. You use a lot of jargon that we and certainly your participants can't understand. But try to be broad and inclusive. You know, if you're doing a registry for a specific question at a specific time, you can be a little narrower. But if you're doing some future unspecified research things, try to be as appropriately broad as you think you might be able to be. I don't have great guidance. Have anything else you want to share?
I mean, I think some of the ones that we see that are successful, they really communicate with the participants. And I think a lot of times people forget that consent is an ongoing process, and I know it's not always feasible budget-wise, and I know that's why it's really important for there's a lot of push now for people to sort of unify some of these smaller banks and unify some of these smaller registries, because if you have resources and you can recontact participants, I mean, we've seen ones with newsletters and all sorts of things. So all of a sudden you want to add something like a blood draw. If you have an ongoing relationship and you build trust in your participants, we see ones where people are willing to come back in and give additional blood. People are willing to fill out questionnaires. If you know, they like to be updated at the types of research that's being done using their information, especially, you know, if you're talking about rather than these broad ones, you know, things that are more disease-specific groups. They like to be kept updated, and they're more than willing to come back in or fill out extra surveys or things like that. And so some of the successful ones that we've seen really sort of build on that, rather than it being a one-time, let me get your permission to grab your medical information whenever I want. If they stay in communication and keep up that contact information, those are the ones who can go back and get extra blood or extra questionnaires and all sorts of things.
But be sure you communicate clearly with them about what you're asking. Many of you may have read the book The Immortal Life of Henrietta Lacks, which is an amazing story about how to do it wrong, and things we've learned along the way. But in one situation in that book, her family is asked to come in and give a blood sample for future research purposes, and they're under the impression that they're being tested for the cancer that killed their mother. And no one ever shares results with them or tells them that that's not what it's about. So they come in and they give blood, and they never hear from these researchers again, and they thought they were being tested for cancer that they're very fearful of because it's already killed one person in their family. So be very clear about what your purposes are. More questions? Go ahead.
What role does legal have, if any, in building registries and data use agreements? Are they part of this process at all?
So we bump most of those questions over to, you know, tech licensing or legal when it's talking about setting up agreements between, you know, institutions or sharing with industry or things like that. You know, the IRB in our office focuses a lot more on participant rights and the regulations that are very smallly defined where we live. And the regulations often say that we don't have to review those kinds of agreements. Like the regulations will say there must be a data use agreement, but the IRB doesn't have to review it. And so that's when our office, you know, communicates with legal as far as, does the protocol and the consent form set up the expectation that there's going to be these agreements, but then legal takes it from there as far as helping craft the specific language and those sorts of things.
For longitudinal registries, when and how do you recommend Recon like recontacting families to get consent from the patient after they've turned 18, rather than from the parents for pediatrics?
So I think on the ones that we see that do longitudinal research, that starts with minors. They think about that ahead of time, and they identify in the consent that when you turn 18, we will be contacting you to do that. And that's usually described both in the parental permission form as well as in the child's assent form, so that when they turn 18, you have a consent form and you've been in contact with them and kept their information to be able to do that. So that's really the spot where the only spot you really need to do that unless you're changing some of the things that you're trying to do. I'm going to save you and us both a little bit of time and effort and build off of this question. One of the things that we frequently see people trying to do in longitudinal research is I want to use the data that I have existing, the on-the-shelf data, and I want to continue to enroll people going forward prospectively. So they're mixing retrospective research with existing data and prospective research with future patients. I'll let you know right now, so we're all on the same page, the IRB will not approve prospective use of, or retrospective use of prospective data. So we won't let you use a waiver to add your patient 5 years from now to your registry after their care is done. So for the prospective portion, for patients you haven't seen yet, participants you haven't yet enrolled, we're going to expect you to obtain their consent. We may give you a waiver for the retrospective portion of your study, but we won't give you a waiver of consent and a waiver of HIPAA authorization for that patient you haven't even seen yet to add their data to the study after you're finished with their care. That's part of the respect for persons issue again, and people having the right to determine if their data can be used, if there's an opportunity for them to do that. We get a lot of requests for that every year. So here's an amendment to add this year's data to my retrospective study. No, that's not going to fly. So save yourself time and effort, make a consent for those folks up front. More questions?
So, among the 7 ethical requirements for human subjects research is validity. And one of the concerns that comes out and is even mentioned in the literature is with registries, or even with any prospective, retrospective research, what are some of the quality assurance measures, and does the IRB consider such measures to be certain that the data that is being pulled is actually the data, the true values that they really are to represent, so that eventually the conclusions that are drawn are they themselves valid?
So this is, I think, the hardest question that we have to deal with in the IRB, to be honest with you. It's a very astute question. If you're not asking the right questions, or more importantly, if your approach to answering the questions isn't going to answer them, then your research has no value. Therefore, any risks involved in your research are not justified for those participants. That's one of the concerns that we must take a look at as an IRB. Along those lines, we try to the best of our ability to get you to clearly explain what it is you're trying to answer and why your approach is a reasonable approach to do that. But understand that this is a peer review process. The reviewer you may have on your protocol may be somebody who's very familiar with this area. We do have quite a few very specialized people on the IRB who review in a number of areas. But not all of your reviewers are going to be that. And there's entirely a chance that you may have somebody who has not any specific knowledge in your subspecialty. To that extent, we have to rely on your ability to give us a clear description. And we also look at things like, has this protocol gone through any other forms of review? For example, are you seeking extramural funding for this? In which case it will have gone through a reasonably rigorous review that tells us that there's probably some validity to your methods in doing this if somebody's willing to give you large amounts of money to do it. That's not always true. When we have questions, we ask you to justify them. And we do periodically have a question that gets raised, particularly in a convened meeting, where somebody on the panel says, can they really get the answer to the question that they're after? And in that case, we're going to ask you, we'll go back to you and ask you to please justify why this is or isn't the case. And sometimes where we see those things is when there's a change. You know, you're studying a particular drug, and all of a sudden the new black box warning just popped up, and you know, this might not be appropriate in your participant population at all. How are you going to address that? And we may ask you those kinds of things if we're aware of them. But again, it's peer review. Just like every paper you've ever published or every grant you've ever submitted, it's a little hit or miss on the level of depth and expertise of those reviewers and what they're going to pick up in your protocol. So we're given a good faith effort to try to take a look at that, and at the same time, trying to not nitpick you to death because we don't know your area. And that's a really hard balance for us.
Well, if there are no more questions, I'll thank our panel, and then we'll get ready for the next group.